Thank you everyone for joining us this afternoon for the September meeting of the Injury and Disability Insurance Data Interest Group. I'm Michael Donato. If you have any questions or queries, just get in touch with me. What do we do in the Injury and Disability Insurance Data Interest Group? For those who are joining us for the first time, well, it's a regular opportunity for people with an interest in personal injury and disability insurance data to share knowledge, exchange ideas and learn from one another. We aim to connect and support members with common areas of interest and specialisation, and we aim to meet bi-monthly approximately, although we did meet just last month, with a member presenting at each meeting. And today we're fortunate to be hearing from Professor Kirsten Vallmuur, who will provide an overview of the Queensland Compensation, Linkage and Injury Management Study, or claims. Kirsten is the chair of the Trauma Surveillance and Data Analytics, a joint position between the Australian Centre for Health Services Innovation at QUT and the Jamieson Trauma Institute, funded by the Motor Accident Insurance Commission. She leads the Jamieson Trauma Institute's Trauma Data Quality and Analytics theme. She has a PhD in psychology and expertise in the analyses and understanding of morbidity and mortality in coded data sets, injury surveillance systems, trauma data linkage, health classifications, and injury classifications. So thank you for joining us today, Kirsten. I'll stop sharing for the moment, and if you want to share your screen, we'll get underway. I should note for everyone as well, this session is recorded, and we will be posting the video to our YouTube channel in the future.
Thanks, Michael. So thank you for the opportunity to present at this seminar series. This is my first time, but I'll definitely be joining in. It sounds like a really interesting group, so I look forward to being part of the group more regularly. So today I'll give an overview of our claims study, our Queensland Compensation, Linkage and Injury Management Study, and every good study needs an acronym, so we go with claims for this one. I'd like to acknowledge our investigatory team that is part of this work. So we've got a lot of people within our JTI team that are involved in this project, as well as working with Queensland Treasury, MACE and the National Injury Insurance Scheme, Office of Industrial Relations, Work Cover and Retrieval Services Queensland. We've got team members from as well. So the broad overview of the aims of claims are the work is focusing on evaluating the quality and value of linking Queensland compulsory third-party motor vehicle accident claims data and workers' compensation injury claims data with health data to address the stakeholder information needs. And so when we're talking about stakeholders, we're talking both from our stakeholders within the health sector, our trauma clinicians that we work with, and the trauma community, as well as the regulatory folks, so the people within the compensation scheme. So we're looking at it from a few different perspectives. The aim is to look at comparing the health service use profile, the costs, the treatment pathways, and the physical outcome trajectories of compensable and non-compensable transport and work-related injured patients using the data. I guess as we've been moving through this work, though, I think one of the broader aims that better encapsulates the work that we're doing is that through this process of bringing all of these large linked data sets together, we're really working as a team to develop best practice injury data linkage logic, to develop the methods in this space, to develop the code and the tools and outputs, which help highlight the patient within the population. So as more and more as we've been delving into this data, and I think we look at population linked data and think of it in a more global perspective, we're really realising the value of focusing in on the patients within that and using this linked data to have a better understanding of the life course trajectory of patients and the patient injury recovery journey. So I guess I want to highlight that first and foremost. And I've got a link there to the protocol paper that this presentation, that the broader claims project is encapsulated in. So, and I'm happy for these slides to be shared at the end too, so you can link in and see those papers. So in terms of the method, the project is a retrospective population level epidemiological data linkage study, a big mouthful, of people who have sought ambulatory care, emergency care or hospital treatment, and or have made a compensation claim and or have died as a result of a transport crash or a work-related injury in Queensland. And I'll explain a bit more of that over the coming slides. Currently, we're analysing a 6-year period of data. We've got data from the 1st of January 2012 through to December 2017. And this data that we're currently analysing includes the CTP, workers' comp, ambulance, ED and hospital data. However, we're just waiting on all of the data sets to come through for an extended tranche of data. We've got the ethics and governance approvals. The data linkage has been completed by Queensland Health, and we're currently having the data sets extracted by the different data custodians. And this data is a period from the 1st of January 2011 through to end of December 2021, and also includes the National Injury Insurance Scheme data, death registry data, and error medical retrieval data. So in terms of how we're selecting cases for this, just to provide some context. So essentially, the study cohort is any individual which is identified in any of these waypoints through eligible codes in the eligible study years. So essentially, if in any of those different data sets, we've got indication that there was a transport crash event or a work-related injury event, then we're aiming for that person to be included in our sample, as well as follow-on care codes that we've got described in the protocol paper, which I won't go into a huge amount of detail today. But in terms of that initial selection of us wanting to make sure we've got people in our data set, it's meeting any of these. So it could be that the person has had an ambulance attendance or an aeromedical retrieval for a transport mechanism. On the work-related side, there's not a code in the data sets that clearly identifies those cases from the pre-hospital area. It might be that in the emergency department, we've got an indication that they had a transport mechanism. There might be a diagnosis code pertaining to transport or work, or there might be a funding code to indicate that they were funded via a transport or work funding scheme. Same with hospitalisation. Compensation data, they may have a physical injury claim with the transport mechanism through the crash data or from the workers' comp data. And on the workers' comp, they may have a physical injury claim with a work-related mechanism. And then in the death data, we can also identify if there's been a transport mechanism code. We can't, there's no clear code for a work-related incident for death, work-related injury incident. So the study cohort, if they meet any of that criteria, will be ideally selected in our data set. So the process is all of those different data sources, data custodians that we've mentioned. We've provided selection criteria to each of those different data custodians. So a large portion of the health data is already within the Queensland Health Data Linkage Unit, so they've got access to those, but any of those third-party data providers will then provide, if the person meets that criteria, they'll provide person IDs to the data linkage unit within Queensland Health. Queensland Health have then done all of that data linkage of linking the people and identifying any subsequent care records for those people. Then they're providing back that person ID and a project ID back to the different data custodians, who then package up their de-identified data set with just the project IDs and their content data, which they then deliver back to the researchers. So the data that are being captured that we've asked for in this data, just to give you a sense of, I guess, the kinds of questions that we can be exploring. In terms of the pre-hospital data points, the types of data that we're capturing are a lot of date and time data, because we're really interested from the pre-hospital component around the patient movements, delays, retrieval pathways, etc. So we'll get the dates and times of the call, of the dispatch of the asset, the arrival at the scene, the arrival at the patient, departure, etc., arrival at the hospital and handover. We also get some data on some of the initial and final diagnoses and vital signs and primary surveys. We've got information about the types of broad treatment that's been performed by the paramedics at the scene, the XY coordinates of the pickup location, which is really useful for us to be able to start to pinpoint areas where incidents are occurring. We get information about the destination of the patient, whatever outcome information they may have at the pre-hospital component, including when someone's deceased at the scene. What the level of response in paramedics are, and any other broad information that's captured in the medical notes around pre-existing conditions, medications, etc. And there's also a really detailed, rich case description. So we've got, in a few of the different data sets, we've got some text narrative as well that we're working with as part of this project. So emergency presentation data, the types of data points that we get from ED data are, again, dates and times of those presentations and discharge, some broad demographics, the facilities. So we'll get the named facility so we can start to track what the patient journey is through the health system in Queensland. Things like the triage category, arrival and discharge modes, payment source, some location details about the patient's usual residence. So if we don't have an ambulance pickup point to be able to identify broadly where an injury might occur, then we'll often default back to the patient's usual residence as a bit of a guide for where an injury may have occurred, as a bit of a proxy. And then some details around things like the primary diagnosis. And for all of the ED and hospital public data, we've also got the clinical costs that that the patient were, that the costs that the patient had to the health system. Hospitalisation data, similar to ED, but richer in terms of a lot more diagnoses data. So we'll get dates and times and patient demographics, facility names, etc., length of stay and ICU length of stay, the arrival and discharge and their transfer to and from different facilities. So a few data points to give us, you know, an even richer idea of how they've moved around the system. We'll get their payment source information, whether they're compensable or not, their location of residence again, and then with all of the diagnoses codes, we'll get all of their principal and other diagnoses, procedures, and all of the usual ICD coded data, as well as their clinical costings. And this is statewide as well. Death and compensation data, death registry data, we'll get the usual date of death, underlying cause, and multiple causes of death. And then through CTP, National Injury Insurance Scheme, and the workers' compensation regulatory data, we get details around the crash and accident circumstances, their injury diagnoses as coded by the regulators and insurers, the claim dates throughout the life of the claim, payment and services data, and various different milestones. And we're working iteratively with the regulators around those data points, because as questions start to arise, more and more, because of the relational nature of a lot of the databases that are captured for these, there's lots of different types of questions. So we've got some core data that comes in, but there's also opportunities to be able to start to build those data sets out as we get you know, more in depth into the types of research questions that we're exploring. So in terms of the data management that's needed in working with linked data, and apologies to people on the call that have worked with linked data a lot and understand all of these complexities, but I was trying to kind of cater for a broad mix. So some of this might be known to many and some might be, you know, new to some. So this is, I always like to use this presentation because I think when people think data linkage, they think that's great. We can link a person and we can understand all of their information, and it's really clear and really easy to understand and nicely packaged when it comes back from data linkage groups. Unfortunately, and particularly in the injury area, it's a lot more complicated than that. We'll often get, so we'll get information back to know that a person is linked over time. We'll know a person is in this data set and that data set, but trying to then reconstruct a patient journey to understand that a person has had an incident at this particular time, that they've been transported to a hospital, that they've stayed at that hospital, have they gone home, have they come back a few days later because they've had some further pain or conditions that have arisen from that initial event, or have they had a subsequent injury event in that time? Particularly as we start to get further and further down the track from that initial incident, people have multiple injury incidents over time. They have long complications from injury over time. So really trying to put together a picture of what a patient looks like over time is challenging. If there's people in this on this call that have been tackling these same things, we're very, very keen to talk with other groups, because it's an area that we've been trying to provide information out to people in the domain, and also identify other people who are tackling these same questions, so we can start to come up with some you know, logical approaches to how we do it. We wrote a paper during COVID times to try and describe the approach that we're taking, but I caveat that to say every day we start working with the data, and as our questions progress, we get more and more understanding of the data, and we start to fine-tune and tweak our logic as we move. So it's a bit of a moving feast. But we have settled on using these terms, and we find that it helps us as a team to be able to talk to each other about what we mean when we're dealing with the data. So we essentially, when we talk about episodes, we're basically talking at a basic record level, a raw record level. So talking about those discrete types of activities when we get linked data, that are some of those basic steps that a person might take. So we might have a single ambulance record for a person, an episode, that might be episode 1. They might then go to and have an ED presentation at a regional trauma service. That might be their episode 2. There might be an inter-hospital transfer, so we might have an aeromedical record for them, and that might be then their episode 3. Challengingly, with pre-hospital data, sometimes there might be multiple records for that same incident. So there might be what we would call episodes in that event if there's 2 ambulances turn up and treat a patient, and we've got two separate ambulance records for them. So we use episodes and records a little bit interchangeably, but it's essentially those very discrete units that we get within the health data. We then try, and this is probably a more straightforward part in the process, we'll group those episodes into what we call an encounter. So with the encounter, we're virtually meaning those episodes that are closely linked in time that suggest that a person has stayed within the health system, been treated for a particular condition, and then been discharged somewhere, home, outside, etc. So it's kind of those contiguously related time points where we group up into an encounter. And often when we're talking about a person's encounter, those groupings are quite useful, because then we can get the overall length of stay for a person from the point where they've had an ambulance pickup through to being discharged from the final definitive hospital that they're in. What's the overall? Because from a patient's perspective, they see that as one bulk of time. That's one experience for them. So an encounter is kind of akin to an experience, I guess. And then we try and group those encounters of care up into an event. So on that front, we might see that a person's had an initial encounter and then come back and had some outpatient presentation, might have been admitted for some further care at a facility related to some follow-up care related to that particular event. So events, we're virtually talking about there's been some kind of injury event happen, and then there's one or many encounters a person might have after that, which are made up of one or many episodes. So I've got a link there to the paper where we've described this. So essentially, when we get the linked data that we're dealing with, our approach as a group is that we try and turn the linked data into a patient story. So we start by creating a unioned record sequence file. So essentially, all of those different records that we get from those 9 different data sources about a person, we try and firstly put them in the order in which they happen, in a time point order and in a logical order, in terms of an ambulance presentation on the same day would come before an ED presentation, even if the timings are quite closely related. So trying to make sure that everything's sequenced, that we can add sequencing numbers so we know the order the records come in. And then we do the work around trying to work out which of those sequences are part of the same encounter. And then the more difficult part, working out whether or not they're actually related to the same event. And in this paper, we've talked through some of the questions that we ask ourselves and some of the initial logic that we came up with to try and decide whether or not follow-up admissions or readmissions might potentially be related to that same incident or not, because it's all nuanced by lots of different rules and regulations around ICD coding, the kinds of things that might be captured in subsequent care, the fact that we don't have a single flag to know that the different encounters are related to the same event. So yeah, it's a bit of a workaround to try and come up with the best way that we can reconstruct a patient journey. So once we do that, we'll add those encounter flags, we'll add event identifiers onto the data sets, and then we put those back onto all of those original data sets as well. So we'll have those separate ones that we can then go through and know, okay, record 5 in the ambulance data is part of the same encounter as record 7 in the ED data and record 9 in the health data. That's all classed as encounter 1, and it might be part of event 1 as well. Then we tend to go through and create useful variables to enable analytics. So we'll do a lot of work around things like grouping up diagnoses and procedures into meaningful clumps and categories. And there's many reference tables that we've been creating, and definitely interested to hear what other people do with that too, because I think that's something we can definitely start to do some sharing of some of that work that goes into creating those categories and groupings, and starting to do that in a consistent way so we can compare. We'll create reference tables then. So we have things like demographic reference tables, timestamps, mechanism reference tables and things, so that when we're working in relational databases and working across multiple statistical packages, which we often, many in the team work across many different statistical packages, we'll set all of those reference tables up so we can work in whatever domain we're interested in, and then working iteratively with the team to develop what the questions are that we have. And that might require us to go back to some source data then and create new tables, new variables, etc., as we need to. So this is just a schematic really of what I described there, that whole moving from those individual files, creating some sequenced, flagged up sequential files, putting those back onto those initial data sets, and then extracting out useful reference tables. So what is the benefit of linked data to answer different research questions? I think I'm still going okay for time, but give me a wave, Michael, if I'm talking for too long. So I think some of the benefits of the approaching this work and using linked data is that we get to come up with a more accurate understanding of what the burden of transport and work-related injuries is. If we're just working from the health sector and just using health data, we get a certain lens as to how many cases there are. But once we start to bring in compensation data, we get a much richer picture of what's going on. So this table is virtually, this is a person level table. So within our 2012 to 2017 data, we had just over 444,000 or nearly 445,000 people in the data set that either had a transport related, that were either transport related, work-related, or had claims for those. So essentially in the rows, we've got whether or not they were a claimant within the CTP data, a claimant within the work-related data, or both in the work and transport, so ever within that time period. And then in the columns, we've got whether or not they were flagged as being a transport-related case. They may be flagged by the health department data, hence why we sometimes there's a much larger portion, there'll be no claim ever made. So nearly 100,000 of our 133 odd thousand transport cases were only identified by the health data. 33 odd thousand had a transport claim. Similarly with work, but with a different preponderance in that 204, nearly 205,000 of the people we have in our data set came from the workers' comp scheme. Came from a workers' comp claim. 75,000 didn't have a workers' comp claim, so a little bit different pattern there, and then some had both. So yeah, 25% of the transport cases had a MACE claim, 71% of the work cases had a workers' compensation claim. So some of those workers' compensation claims will be people who have had an injury incident but may have never had a ambulance, ED or hospital admission, might be more community treatment. So in terms of looking at the changes in the claim proportions over time, so this is just an over time and kind of showing those patterns over time. So as you could see before, there was a much larger portion of the transport ones that didn't have a claim. So this is up to around your 70% odd of cases that didn't have, 75% or so of cases in each year didn't have a workers' comp claim, a CTP claim, as opposed to the workers' comp where we had a much larger proportion where we had a claim. And then just this again just reiterates that point of how in our data set, how we're identifying our cases on the workers' comp side, more so from the workers' comp data. On the health, on the transport side, we're identifying them more from the health-related data. So I'll just quickly go through, so this was the slide that I showed before, but just to give you an idea of what that then does to the numbers when we start to look at things via episodes, encounters or events. So yeah, you can see here the sheer magnitude of the differences in the estimates when we move from looking at someone's index episode, which is flagged as being a work or transport one, to the entire encounter of care for that episode. So just looking at the transport ones, while the summed length of stay for episodes across the 6 years, and this is summing across 6 years, while the summed length of stay when we just look at a first episode across the 6 years amounted to around 71,000 bed days, when we actually grab all the episodes that relate to that first encounter for that person, we end up getting 418,000 bed days. And then if we scale that up to how we're currently describing things into index events, we reach 483,000 bed days. So essentially it's, do we just look at that first index episode? Do we group it into an encounter? Do we group it up into the event? You can see the size of the estimates that we start to reach. And we can't do those encounter or event type maths without linked data. Essentially, if we just get data sets that are sent to us without any linkage, all we can tell is at that episode level. In regards to the costs, we also see those same kind of scale of differences. So if we were just to look at that first episode for a person, we'd estimate that, that the groupings would come to around 157 million. When we actually group them up into the entire event for that index event for a person, we end up with over 1.2 billion, and that's just public health hospital costs. So in terms of the gaps, some of the gaps that linked data can fill for us in the compensation scheme, we can get much better detailed information about those pre-hospital observations and clinical signs, what's actually happening at the starting point of an injured person's journey. Information about the initial clinical characteristics and acute clinical management to help with forecasting and identifying trajectories of patients. We can look at, get much better information around comorbid conditions and previous presentations that people have, and also a better understanding of what the costings are to the health department. We can also start to look into what are the similar cohorts that don't make compensation schemes, so getting a better understanding on what the pathways are of people who do and don't make compensation claims within the system and the subsequent health service use. So some of the next steps for our claims team, I'm almost finished now, Michael, is applying the logic and codes that we've built on this first tranche of data to the larger tranche of data and analysing and publishing those findings. We are working with a geospatial visualization team to develop an injury atlas platform. So we've done an initial version of that and we're onto the beta version of that to start to be able to showcase in a much more interactive manner where incidents are happening, how patients are moving across the system, and provide some easy dashboard type approaches and filters so we can interact with the data a little bit better and make it more palatable for our stakeholders. We're continuing to refine those questions as we get more familiar with it. And as I said today, we're definitely interested in building up our collaborator network and working with other people who work in this injury linkage space, because I think the more we can get consistency around the ways that we approach the data, then we can start comparing across states and across different research studies to see what is actually happening for these patients and claimants. So my contact details are there. The QR code will take you to our OSHI page where we've got a bunch of our other research projects that we're working on, as well as details about this one and links to publications and so on. But yeah, happy for questions or feedback.
Fantastic. Thank you, Kirsten. Yeah, we'll open up the floor to questions if anyone's got any. I know I do, but we'll open up to everyone else first. Alex? Is that a thumbs up for a question or thumbs up generally?
So thumbs up for a great presentation. Cool. Thanks, Kirsten. I do have a question as it happens, so Michael, which is sort of a technical one. So I'll ask it while I can. So I really appreciated your description of events and encounters and episodes. That's something we have grappled with as well in the hospital data that we've linked to some workers' comp data in New South Wales. And so I'll chase up that paper that you suggested and have a close look at it. I guess my question is just more about the sort of public reporting of that data and what we see in information that's put out by our public healthcare systems is usually just at the episode level, as I understand it.
Yep.
And so it's rare to get the sort of understanding that you're developing, I think, here. Is it, do you have that same sense? But that's what we're looking high and low for examples of studies or just public reports where they put it together. Daniel Griffiths, who's on the call, was sort of leading this for us with a student, and we just came across hardly anything.
Yeah, absolutely. I am hopeful that with all of the linkage work that AIHW are involved in, that there might be some more reporting at an encounter type level. But I think at the moment, it's still more of the technical aspects of linkage and not really starting to think then about how that gets grouped together. And I think injury is such a nuanced thing that it takes a whole other kind of level of understanding, because people do move in and out and move across different services. And we find, particularly in Queensland, being such a distributed, dispersed population, that there's such a lot of movement, around facilities, and it's quite a technical task to group all of those different episodes into an encounter and report it that way. But I think it gives a much more richer understanding of what the actual length of stay and burden is from a patient's perspective, because a patient doesn't care if they're snapped between 5 or 6 different episode types as part of their encounter. They just see it as one big long encounter. So I think it's trying to put that perspective on how we present the data.
Yeah, I agree. And as we're talking, sort of an opportunity for a study occurred to me, because we've got some similar data in New South Wales in people with work-related injuries. So maybe we could run some sort of comparative New South Wales and Queensland sort of side-by-side analysis or something.
Yeah,
interesting.
That'd be really interesting. And as I said, we're more than happy to share. We've developed code in so many different packages because we all use different packages, and we're talking about setting up a GitHub site and putting our code up in places like that so that we can start to, make it a lot more open source and share code amongst each other. So happy to talk further.
Fantastic.
Thanks, Alex. Any other questions from the viewers? I might just, rather than a question, just an observation. I mean, it's always astonishing to see the application of this linked data sets, and it's always the thing that struck me was, one, the actual proportion of people with a work or transport related injury who actually make a claim, which we've always suspected, or effectively known is lower. The claims are lower than the proportion, but for transport related injuries, that's a big gap. wasn't expecting it to be that large. And then also the difference in number of bed days between episodes and encounters. I mean, was that an expected gap when you started the project, or a bit of a surprise?
Probably a bit of a surprise, really. I mean, we were only, when we started the project, that true appreciation of the, number of different episodes that can become part of the one encounter, and how long, when that all is strung together, what that means in terms of the sheer volume of bed days and costs. And I think that the disparity that you're talking about with transport there, given Queensland is an at-fault scheme, so we were expecting some of that difference there. And there is some further work to be done with fine-tuning which groups of transport cohorts we look at to, more clearly group out the ones that are potentially might be eligible to make a compensation claim versus those that are from a mechanism that was never going to be eligible within the compensation scheme. I mean, we're taking a fairly broad public health approach in that we're interested in all transport cases anyway, because we're interested in what that burden is and what that looks like. But I think it is interesting, to start to pick up on where there's potentials where people may have been able to make claims and haven't made those claims, and what they look like and what the outcomes for them are compared to those that do.
That's yeah, that will be interesting to see what those factors are. Yeah.
I have another question, if we have time, Michael, which is sort of about people who get injured and don't make it to hospital, which is sort of much harder to track through our health system, I think. And if you have thoughts on how to approach that for both people injured in motor vehicle crashes and at work. And
so are you thinking of the people that are deceased before they make it to the health system, or those that are more community treatment?
yeah,
So
no, people with,
less severe?
I guess, less initially severe conditions who just might not present at an ED or might not be picked up by an ambulance, but you know, quite a proportion of them go on to have pretty complex cases,
Yeah.
particularly in our workers' comp system, and I suspect in our CTP schemes and after motor vehicle crash as well. So
yeah, and I think that community care side of things is really challenging, and trying to, I mean, apart from linking in Medicare data, but trying to identify injured diagnoses in Medicare data is very difficult, and if not impossible. What we're interested to see in working with workers' comp, and with probably less so NISQ, but more so workers' comp, in that they are providing services and payments, and you know, have a good record of what has actually happened in the community. That 70% or so that we saw there that are claimants that don't necessarily have any touch point with the health system, we will be interested in looking at that data and saying, well, what are their touch points within the community health system, and are there any opportunities to be able to tap into that data and access that data in a more regular way? We've stayed more so with our work, you know, over many years, more with the kind of more tertiary care sector, because the community health data has been somewhat lacking. But I think as we get more innovations in digital health and we start to get better data capture across the system, we should be trying to see where we've got opportunities to tap into those areas. So I think even starting with what are the known knowns from where we actually have got claimants, and where they actually do reach out to and start to investigate, are there actually data sources there that we could be tapping into more regularly than what we do?
yeah, I agree. That might be another opportunity for a follow-up discussion, Kirsten, because
Yeah,
that's a group that we're interested in looking at as well. And I know Shannon Gray, who's on the course, doing a linkage project with CTP claimants and Medicare, for instance, and PBS. Hopefully in a couple of states, which will include not just those hospitalised, but others as well. So
some of those ones too, Alex, I'm interested in, is that what we are seeing too, where we've got some of those, the linkage for that subsequent care, we're seeing some of those people who may not have initially had an acute injury presentation, but they've got a workers' comp claim, but then a year or two down the track have a musculoskeletal condition and some kind of procedure for a shoulder or a knee or something like that. And starting to track that through and go, okay, well, are those kinds of conditions, you know, does that relate to their initial workers' comp claim? Did they have a workers' comp claim for a shoulder or a knee, and do those kinds of matchings? Because I think some of them do start to come into the tertiary healthcare sector, but maybe not, you know, for the first year or two.
Yeah, not as an acute thing. We certainly see that
Yeah.
in the claims data that we've looked at, Michael, don't we? So
Yeah, I mean, I was just thinking on that note, you know, that the portion of people with a musculoskeletal claim, for example, going on to get mental health services, and services that are not immediately related to their compensable condition. Shannon, again, who was on the call, has done a lot of work with this, and you know, in back pain claims, we see a small proportion of people having mental health services, but a long way down the track in their claim. So it'd be interesting to see if they're just having them a long way down the track, or they were having them earlier, but from a different funding source.
or even hospital admission for surgery or something, you know, for what was initially sort of a low back condition that, you know, may not have been managed appropriately.
Yeah,
absolutely. We are running out of time there, so we might just leave it there. But if anyone has any other questions, get in touch with Kirsten via her contact information, or myself, or if anyone on the call would like to speak at a future meeting of the Injury and Disability Insurance Data Interest Group. We have to come up with a fun acronym for that at some point, because it's quite a mouthful. Please get in touch. We'd love to hear from you. And thank you for presenting today, Kirsten. That's really fascinating.
no problem. Thanks for the invite.
Bye, Ron.